topic suggests, I'll be mainly focusing on flexion instability after TKA and will only briefly touch upon the other types of instabilities due to time constraint. Instability is a common cause of early failure after TKR, accounting for about 10% to 22% of revision TKAs. Although gross laxity can be easily diagnosed clinically, subtle instability poses bigger diagnostic challenges as the clinical features are less prominent. So high index of suspicion is always required. Management will depend on severity of symptoms, type of instability, and type of the prosthesis used. Coming to the types, Kelly, Vince, and colleagues describe 4 types: extension instability, genu recurvatum, flexion instability, and global multiplanar instability. Most of the modern literature, however, includes one more type, that is mid-flexion instability. So flexion instability is instability following TKA, which can be defined as abnormal and excessive displacement of a knee prosthesis accompanied by clinical failure. And flexion instability per se is presence of a larger flexion gap than the extension gap. Coming to the causes, one of the common causes is inability to balance the flexion and extension spaces during the surgery and leaving the flexion space bigger than the extension. Gradual laxity or incompetence of the PCL in shear knee designs can sometimes happen. And this generally happens if the condition of the PCL is not healthy at the time of surgery, or the surgeon tries to balance the flexion space by doing partial recession of the PCL. Although flexion instability may also occur with PS knees designs for other reasons. And suboptimal distal femoral resection in presence of FFD is another cause of this condition. Excessive posterior femoral condylar resection with undersized femoral component also leads to this condition. So clinical features, patient gives a sense of distrust with the knee. The knee tends to shift or slide, and it happens classically while rising from a chair or climbing stairs. Often the knee never felt well since the index surgery, and some patients with shear knee may have excellent early flexion, but soon they develop feeling of instability as the anterior restraints, that is quadriceps and the extensor mechanism, fatigue, and anterior knee pain develops. Flexion contractures can also develop in cases with flexion instability, and the knee tends to assume a flex resting position in this setting and leading to this contracture. And some patients present with recurrent low-grade effusions in the knee joint. In physical examination, excessive AP translation is found in 90 degrees of flexion. However, there is no consensus regarding the quantifying the amount of motion. Abdul et al. Has suggested mild as less than 5 millimeter, moderate 5 to 1 centimeter, and marked is more than 1 centimeter. And Pengnano et al. Has described a posterior sag sign like the which you get to see in the PCL tear. And Vince et al. Also has described another test in which the patient is asked to sit hanging his leg on the side of the table, and if flexion instability is present, the larger flexion space will cause the tibia to descend and distract the joint. And when the patient is asked to actively extend the knee, the tibia can be seen getting pulled up to articulate with the femur before it starts to extend. And diffuse periretinacular tenderness, pes and serenus tenderness are also one important finding sometimes found. And on radiograph, a complete weight-bearing radiograph series, including AP, lateral, and skyline views should be done to scrutinize the fixation, alignment, and sizing of the component. Full-length hip, knee, ankle scanogram should be done. And in the lateral radiograph, one should know the slope of the tibial tray and posterior femoral condylar offsets. The size of the poly insert and other clues, such as patella baha, may also suggest postoperative alteration in the joint kinematics. CT scan is not mandatory in flexion instability cases per se, but however it may be useful to give other clues for other types. In surgical management, revision TKA is the option. Kelly, Vince, and Abdel et al. Both suggested a sequence of surgical corrections for flexion instability. Firstly, create a stable tibial platform with corrected tibial slope if slope is excessive, and flexion gap balancing with larger and appropriately rotated femoral component. Upsizing the femur may necessitate use of posterior femoral augments, as mentioned earlier. And if the above measures fail to get the adequate balance, then resection of more distal femur and proximal placement of the femoral component will be required. The surgeon should aim for less than 5 millimeter anterior tibial translation after patella is reduced and knee at 90 degrees of flexion. And surgical management, Flexion instability can be accompanied also by medial lateral instability as well, in which case one needs to use a varus valgus constraint implant. And in some situations of flexion instability, flexion space is too large to equalize your extension space. If the mismatch is more than 10 millimeter, then one has to go for hinge prosthesis in such cases. Other types of instability after TKA, one important type is mid-flexion instability. It's a long-debated entity introduced by Martin and Whiteside in 1990. There is lack of consensus, however, regarding the most aspects of MFI, to the extent that some authors dismiss it as a concept which doesn't exist in reality. Kelly Vince, who is considered an authority in knee instabilities, has also dismissed MFI as woolly thinking in this JBJ's article in 2016. However, things have moved on since then, and MFI is getting more and more interest now. It is described as a phenomenon where their knee is stable in full extension and 90-degree flexion, but instability during mid-range of flexion, that is 30 to 90 degrees of flexion. MFI occurs when joint line elevation leads to non-coinciding of the flexion axis with the MCL insertion point. The most common situation causing this is usually an arthritic knee with FFD that is replaced by resecting additional distal femur, while posterior releases and posterior osteophyte clearance have been suboptimal. And in management, restoration of joint line to native position by revising femoral component plus or minus posterior capsular release is the answer. And an extension type of instability, correction of the coronal plane malposition of implant or to achieve balance by soft tissue releases, which insertion of thicker insert may be required. If collateral ligament is deficient, revision to a CCK type of implant may be required. In GNU recurvatum, in absence of neurological cause or collagen tissue disorders, revision of femoral component to a more distal position using augments may suffice. In presence of above conditions like neurological or connective tissue disease, then hinge prosthesis to be used. In global instability, in mild cases where ligaments are intact, exchange to a thicker poly insert should work in some cases. However, in presence of ligament or bony defects, rotating hinge implants have to be used. Coming to the outcomes, as mentioned in this article in the Journal of AAOS by Jeffrey Stembo, it is observed that patient outcomes after revision TKA for instabilities show less amount of improvement for reasons not clearly known when compared with revisions for other TKA failure etiologies. Thank you for your kind listening.